Hello, everyone, and I really hope that you all are doing fine. And today I made this video and I will do these two cases, which is Odell case 45 and 46. I want to do these cases because these are very much related to the topic that we are doing right now in the TG, which is the oral mucosal disease. There are some other scenarios or some other cases from Odell as well, which do cover which are about oral cancer and about the malignant lesion or about the ulcer. So what I will do is I will write it down on my Instagram, or I will try to tell you like with which TG case, which Odell cases you need to be covered. Okay, so I will give you the list. Um, but I just want to show you, if you will read all these things together, that would be helpful for you. So as we read in the TG class that the last topic that we covered is about leukoplakia, erythroplakia. So is what we will be seeing here. So let's start this case, which is the white patch on the tongue. Okay, so here a 52-year-old woman would come to you. She has a white patch on her tongue, and you need to make a diagnosis and you need to decide an appropriate treatment. What is the patient complaint? She has no complaint. Okay, because as we read in the TG that the early presentation has no sign and symptom, in the late presentation only patient would come to know that there is pain, there is discomfort, the tongue is immobile, or there is difficulty in mobility of tongue, but the teeth are very mobile in that area. So here she has no complaint until now. What is the history of complaint? You have just noticed the lesion in a patient attending for the first time in a several year. There is no written record of this white patch in her notes, and the patient had noticed the lesion but had ignored it. She said that because this was not giving her any symptom, so she just ignored it. She thinks it has probably been there for several years. Then, what is the medical history? She is fit and well. She smokes 4 cigarettes a day and drinks 4 to 8 units of alcohol each week. So, did you remember the risk factor that we read in TG, which is the smoking and the alcohol? So, both of them are present here. Then what examination you did? First, you will start from the extraoral. You checked her lymph node, but they were not palpable in the neck, and there are no abdominal findings. Okay. Then inside her mouth, apart from this lesion, everything else was fine. Then the appearance of this lesion is shown. What do you see? So this is a flat and homogeneous white patch. We read in the leukoplakia topic that it could be two types. It could be homogeneous or it could be irregular. So this is the homogeneous white patch on the left lateral border and ventral tongue mucosa. And we also know that the lateral border of the tongue is an risk site, right? So it is a high risk site. It is well defined and varies slightly in whiteness. Then, if you were able to feel the lesion, you would find that it is soft and feels no different from the surrounding mucosa. Then what would be the differential diagnosis that can come into your mind, like what it could be just by looking at the picture? Okay, so they're all almost all oral white patches are caused by increased keratinization of the epithelium. You know that why do these lesions appear white? Because they are over keratinized. Keratin absorbs water and appear white, and it is brighter white where it is thicker. The exception is a chemical burn where the white surface layer is caused by a necrosis or ulceration. Common and important causes of the white patches are: firstly, it could be normal, which is this thing also we read in TG, like the normal variants could be leukoedema or the Fordyce spots or the Fordyce granules. Okay, then the inherited epithelial disorders like that they run in family, which is the white sponge nevus or Pachynokia congenita. So just like ignore my pronunciation of some words because these medical terms are very hard for me. Uh, I struggled a lot with these pronunciations. Yeah, okay. So, like some other causes could be traumatic, which might be a frictional or any cheek or tongue biting. You might have noticed like some people do have cheek biting habit and they do have white colored line in their occlusal plane line and the chemical burns. Okay, then the other causes of the white lesion could be any infection. It might be coming from fungus, which is thrush, or chronic hyperplastic candidosis, or the chronic mucocutaneous candidosis, or hairy leukoplakia, or the syphilitic, which is the bacterial leukoplakia, or the hairy leukoplakia. Okay, then the lichen planus and similar condition. So the lichen planus, lichenoid reaction, lupus erythematosus, or graft versus host diseases. So these are immunity-based diseases, immunological diseases, and they also appear white in color. And unknown origin, which is the leukoplakia, as we read in TG. So leukoplakia is of unknown origin when you have ruled out every other thing. So that's the point where the leukoplakia is. So it could be of several types, and the smoking related, which is the smoker's keratosis or stomatitis nicotina, or the smoker's palate, um, or the neoplastic, which is the squamous cell carcinoma. Then which lesions would you include in the, so these are the common general lesions that could lead to white patches. So what you would consider in this particular case, which are the likely one: idiopathic, which is the leukoplakia, then the smoker's keratosis. Less likely would be candidiasis, or the lichen planus or lichenoid reaction, or the frictional keratosis or squamous cell carcinoma. These are less likely at this stage of time. Okay, so what is leukoplakia? The literal meaning of leukoplakia is a white patch. This the term is correctly defined as white patch that cannot be characterized by any other lesion. The use of this term is correct only after all possible non-causes have been eliminated through whatever investigation are required. Unfortunately, the term leukoplakia is often used very loosely in the clinical context, whether for a white patch of any cause or for the small minority of white patches with a risk of malignant transformation. This has led to a great confusion, such as like we commonly use leukoplakia term with candida leukoplakia, hairy leukoplakia, syphilitic leukoplakia, but ideally it is a word which does denote white patch, which is basically of unknown origin only. Okay, so now they are saying that justify your differential diagnosis that you have mentioned here. So, leukoplakia or idiopathic white patch, although there are many groups of well-defined white patches, the largest single group is that for which no cause can be identified. This is therefore a likely diagnosis for the present lesion because there are no clinical features that suggest a specific cause. So, in this case, patient do not know that this is going on, and there is no sign, there is no clinical cause why it might be happening. So that's the reason it is leukoplakia or idiopathic white patch. Okay, the group of idiopathic white patches includes some more specific terms that might be applied to this lesion. So the more specific terms are mainly sublingual keratosis or the smoker's keratosis. Sublingual keratosis is the white patch that affect the floor of the mouth or the ventral tongue, and the lesion here are considered to have high risk of malignant transformation, right? The typical lesion is bilateral and may be extensive in the floor of the mouth, often with a wrinkled surface of ebbing tide parallel corrugations. However, a sublingual keratosis is defined only by its site because it is lying at the lingual, like the ventral side of the lingual of the tongue. So that's the reason its name, sublingual keratosis. And any white patch affecting the ventral tongue or the floor of the mouth could be termed as sublingual keratosis. The present lesion is only just extend to the ventral tongue, right? So it is present on the lateral border of the tongue. Then the smoker's keratosis, it is a white patch of no known cause and found in the mouth of a smoker. This type of lesion is a flat, homogeneous white patch and sometimes with a finely wrinkled surface on non-keratinized mucosa. So what are the non-keratinized mucosa such as the tongue, gingiva, floor of the mouth? Smoking is assumed to be the cause, although there is rarely any evidence to support this unless the lesion arises where the smoker habitually holds a pipe or a cigarette. Okay, this patient's lesion could be smoker's keratosis, but this is not a particular useful label and does not imply that it should be treated any different from because here they have mentioned it is only a label, which is a keratosis or a white patch happen in the mouth of a smoker. Either you can give it a name as smoker's keratosis or a white patch or a leukoplakia. The management would be similar, right? And smoker's palate is a separate condition. So the smoker's palate, you know that those are the like the pinpoint projection on the palate of the patient who does smoking. So that is completely different condition. Then the frictional keratosis, it is also common, but it does happen according in the occlusal line on even dentulous alveolar ridge and on the lateral tongue. It may be associated with sharp teeth or restorations and be unilateral or bilateral. Okay, frictional keratosis usually merges gradually with the surrounding normal mucosa and is not as sharply defined as the present lesion. Tongue biting also causes keratosis, but the surface is often shredded, and there may be similar lesion on the buccal mucosa, usually just behind the commissures, unless the lesions are associated with clear evidence for of habitual biting. So we cannot just specify it, right, as a frictional keratosis. Here they are just trying to prove that this is leukoplakic or this is idiopathic origin. This could not be anything else. So the other reason to make any or to form any plaque is white plaque or white patch is the candida leukoplakia. These lesions arise most commonly on the post-commissural buccal mucosa and the dorsal tongue. Okay, dorsal surface of the tongue, and may be associated with red areas. These lesions are more common in smokers, which is our patient. Unless the site is typical, it is almost impossible to make the diagnosis clinically. Biopsy and resolution following antifungal treatment are the most useful indication to identify these lesions. So if you want to confirm, you need to do the biopsy, and you can also try by prescribing the patient the antifungal treatment if that does help with the white patch. The present lesion is not typical, but this cause cannot be confidently excluded only on clinical ground. Like you do need to do certain investigations such as biopsy. Then the lichen planus and lichenoid, they may cause homogeneous white patches. This more unusual presentation seems to be more common in smokers, and it is not at all clear whether these so-called plaque type lichen planus lesions are a genuine presentation of lichen planus or are induced by smoking. So to be sure of diagnosis, it is advisable to find evidence of more typical lichen planus elsewhere, because lichen planus does happen on the body, so you need to find it on anywhere else as well, or in the buccal mucosa or in the form of desquamative gingivitis, but there is no other evidence in this patient. Then but we cannot just exclude it only on the clinical ground, so we can do certain investigations. Okay, then the other form is the squamous cell carcinoma diagnosis must be included for any white patch, as we read in TG that we need to be more cautious if the patient has any lesion. Okay, so without an unidentified cause, the chances of this particular lesion being malignant appear low, although it is in a high risk site, which is the lateral surface of the tongue. It is a flat homogeneous lesion without ulceration, red areas, speckling, or induration. The patient is a light smoker and is in the risk age group. We know that the risk of getting the squamous cell carcinoma increases with the age. For squamous cell carcinoma, although very unlikely, this just might be a carcinoma. Then, which white lesions have you excluded? Explain why. Leukoedema and the patches of the Fordyce spots. So, they are the normal variations and they primarily affect the buccal mucosa. Leukoedema causes a milky white appearance. What you can do for these things is just look in the Google to see their picture. How do these lesions look alike? Then you would come to know and it will fit in your mind and you won't forget. Okay, so leukoedema causes a milky white appearance and is usually seen in those of African descent. Fordyce spots are sebaceous gland and they originally form clusters that resemble plaques but have a slightly yellow appearance, and individual glands are usually visible within the lesion. Both are present from childhood and neither affects the lateral tongue. Okay, so those are the if we have excluded them, because if these two would be the cause of this patient, then they should be present since the birth. Okay, and they should not cause any, and their site is also different, and their origin is also different, and there is no very good link with them. The other lesions are white spons nevus and Pachynokia congenita. They are rare and they are inherited, like they are genetic diseases that cause diffuse keratosis or multiple discrete white patches. And the possibilities are excluded on the basis of the localized extent of the lesion, age at onset, because they are generally genetic, so they might be happening since the birth, and the absence of other skin and nail abnormality and family history. Then aspirin burn or other form of chemical trauma is unlikely. Such trauma results from the application of aspirin directly to the mucosa, usually in response to toothache. Lesions are mostly if the patient, for example, if the patient has toothache and he has put the aspirin in that area, the lesion would more commonly be seen in the buccal sulcus as compared to the tongue. Okay, and affect the mucosa on both sides of the site where the tablets were placed. This is an unlikely possibility and may be readily excluded through direct questioning. Then the thrush, which is the fungus, affects larger areas of the mucosa and at least a part of the lesion can be wiped off. As we know, these leukoplakia, we cannot wipe off or remove them. And the underlying mucosa is generally inflamed in case of candidiasis. Chronic candidosis rather than acute candidosis could have caused the present lesion as discussed above. So as we discussed here, like we cannot just exclude it only on the clinical ground. We can do biopsy and certain other investigations. Then the hairy leukoplakia usually forms bilateral white lesions along the lateral border of the tongue. Usually it is seen in immunosuppressed patients, which are the HIV patients. Okay, although the possibility of an undiagnosed HIV infection cannot be excluded, the appearance are not typically of hairy leukoplakia. Lesions remain limited to the lateral tongue in almost all cases. Then the syphilitic leukoplakia, it may also be readily if the patient must have tertiary syphilis and the site of the white patch is the dorsum of the tongue. And then the smoker's palate or the stomatitis nicotina, as I told you, that it affects the hard palate. of and it generally happens like a pinpoint projection, and that can happen due to either pipe or cigar smokers or of a heavy smokers. So what investigations would you do? You would do the biopsy, okay, to rule out if it is a carcinoma or what is the stage of the dysplasia or the malignancy. Okay, so the reason for performing biopsy are to exclude or to confirm the cancer. If not malignant, to determine whether there is any sign of dysplasia or not. To identify if to rule out if it is a candidal infection. To help identify specific conditions and causes for the lesion, if it is not in cancer, to help what is actually is, because it is a diagnostic test which will help us in making the diagnosis. Is this lesion suitable for biopsy in general dental practice? So here they have mentioned here, yes, that if you are competent enough you can do that, but according to TG, as we read, that the best person to do the biopsy is the oral medicine specialist. If he is not available, then the oral surgeon or the other specialist can do. And in rural cases, if the specialist advice or the specialist referral can delay the treatment, then you can perform the biopsy, but only after seeking expert advice. Okay, then what would be the what features of a white patch might indicate malignancy and contraindicate performing biopsy in dental practice? What are the areas which are which are more suspicious? Which is associated red areas, there are speckled areas, ulcerations, induration, if the lymph nodes are enlarged and draining the site, and lesion in a high risk site. So these are the signs which are denoting it to be a malignancy. Is a biopsy really necessary? Are there no less invasive tests that could help identify risk lesion? So there are certain type of biopsies that they have mentioned here, like exfoliative cytology or the brush biopsy, where they just take out the superficial epithelial cells with the help of stiff bristle brush, and they just observe them and study them, and which would be more conservative method of doing the test. Or the other method is the toluidine blue staining, and it is by the dye can be applied on the lesion by dabbing or in a mouthwash, and it is claimed that the lesion that retain the blue stain indicate a high risk of dysplasia or carcinoma. So these are some of the method that they are telling. If because biopsy is bit invasive procedure, if you want to avoid that, what options that you have, or the optical test, which is the fluorescence test, or the chemiluminescent light examination. Okay, so all these tests are screening tests and none is of sufficient accuracy. So you can perform them. They are less invasive than biopsy, but they are not very good in diagnostic. Until such techniques are validated, biopsy remains the safest and only justifiable course of action. Studies shows that the patient do not find biopsy a traumatic procedures and that healing is rarely problematic. So biopsy is you can do biopsy. It is not very invasive procedure, to be honest, and it is an investigation that any dental surgeon should be able to perform, and it should not be delayed. You cannot delay it, because if there is any chance of cancer or any problem like that, that could spread and it would be dangerous for your patient. How much would you remove? And like, this is not for us, because according to DG we are not really a good individual to do the biopsy, but still if you want to study, you can learn, or for your just for your knowledge, you can study, like when you need to take a patch, or when you need to take a sample, it should be 10 millimeter long and 4 to 5 millimeter wide. Okay, and it should also contain the normal area and the abnormal area. The biopsy specimen is required to assess dysplasia. So what is dysplasia? It means that the microscopic changes that indicate a risk of malignant transformation. What are the features of epithelial dysplasia? We will read in table 45.2. So these are the abnormal features of dysplasia, which is failure to form an organized epithelial layer. So these are some histological signs that are happening inside the cells, but these are the main points, which is the epithelial layer would not be organized. There would be disordered maturation and differentiation of single cells, abnormalities of cell nuclei, and abnormal growth regulation. So these are the signs that we see as dysplasia in the slides of the biopsy. How do these changes differ from the histological changes seen in squamous cell carcinoma? So, as we read in TG, that like there are certain stages of the malignancy, which would start from the mild dysplasia, moderate dysplasia, and severe dysplasia. And severe dysplasia can also be known as carcinoma in situ. And afterwards, the stage which would come is the squamous cell carcinoma. So it would move according to the dysplastic lesions. And it is more likely like histopathological slides, like in this slide. So mild, moderate. So if the dysplasia is only around this stage, then it would be mild, moderate, then severe would be carcinoma in situ, and then the squamous cell carcinoma. Okay, are there more accurate predictors of transformation? So this is just the total DNA content of the epithelial cells, so the ploidy analysis. So these are some of the other ways that can help us in studying if there is any chances of malignancy in that patient. Does dysplasia always progress? No, it does not always progress, and in some cases of mild dysplasia, it may regress. Okay, then histopathological features are shown. So you can read about these histopathological features, what they want to highlight here. This is showing mild stage of dysplasia, like the nuclei, it is prominent, and there is mild features of dysplasia here. What is the final diagnosis? It is an idiopathic white patch, and with mild dysplasia, this is a lesion with a risk of malignant transformation, because it is an leukoplakia, so there is a chance of malignant transformation. Then what would be the treatment? Treatment would be, it would depend, like according to TG we would only be referring, but they have explained in detail, like they have uh, they have given the patient all the options. The following principles of treatment apply to all idiopathic white patches. The patient should stop smoking and moderate her alcohol intake, because those two are the risk factor. If there is any candidal infection, it should be treated and periodically checked for any recurrence. In this case and other in which dysplasia is mild or absent, it is appropriate to monitor the lesion, and initially at 3 monthly interval and then to 1 yearly interval. Okay, if provided the lesion does not change significantly, the aim is to detect any change in the severity of dysplasia or malignant transformation, and this may require biopsy from time to time. Okay, lesion with moderate or severe dysplasia may be removed through either through surgical way, chemotherapy, or radiotherapy. So there are certain type of treatment available. In addition, it is important to remember that dysplasia may affect any mucosal areas exposed to tobacco, smoke, and alcohol. There is a risk of carcinoma arising in the pharynx and in the respiratory tract, and symptoms arising from these areas indicate a need for endoscopy. Then what would be the prognosis of this? Right, so the features associated with increased risk of malignant transformation are listed here. So these are, if there is any dysplasia, genetic status, then what is the site of the lesion, what is the color, if there is more red color, so there would be more chances. Then the how is the surface, is it ulcerated, is it homogeneous, then if the patient is using tobacco, with increased age, male, gender, more increased size, more duration, multiple areas, family history, candidal infection. It also increases the risks, and changes in clinical appearance and underlying conditions. So these are all the risk factors that they have given that can help in changing the this white patch into malignant. Okay, and what would be the in this case the lesion remained unchanged and the patient was reviewed at 3 monthly interval for 1 year and 6 monthly interval for 2 years, and she remains under annual review. 4 years after presentation, a second biopsy was done and the degree of dysplasia was still mild. Excision was considered because the lesion is relatively accessible and is at the site of high risk of carcinoma, but it was not carried out because the dysplasia remains mild and the patient wants not to have a surgery. So the patient decision is the last decision, right? So he, if she does not want to have any surgery, so then no surgery, but we will recall her regularly to measure the degree of dysplasia. So this is the leukoplakia chapter, and in the following page, another white patch on the tongue. This chapter is also similar to this one, but it would have more sign and symptoms. Like you will learn, like this is quite similar, but in this chapter, it has turned into a cancer. Here, it's just an leukoplakia. So if you will read these two chapters together, you will get an idea, and I will also give you and provide you the list of the chapters or the Odell cases that you need to do with the following TG topics. Okay, and I really hope that my video is helpful for you, and thank you so much guys for your response, for your like replies, for your likes. I'm very grateful, and I will see you guys in the next video. Good night.